Good afternoon, everyone, and thank you for being here at the TxRx Echo series. This is a training brought to you by the Center for Substance Use Training and Telementoring CSAT, a division of the Be Well Institute at UT Health San Antonio. Our friend Angela Riley will not be able to join us today as a facilitator, so I will be facilitating this conversation. My name is Andrea, and I'm excited to be here. But before we start, I want to remind all of you that this session is being recorded for later distribution, and you may find it later at our Be Well Texas YouTube page. In the meantime, please continue adding your names, email addresses, and affiliations on the chat. We will need this information to confirm your attendance to this class. But if you're joining via phone, you can always send us an email at cstat@utesca.edu, and that way we will associate your phone numbers with your names. So in today's session, we're going to start with a didactic presentation. We want to welcome Jackie St Germain, our speaker today here at TxRx. And after her didactic presentation, as usual, we will open the floor for your questions and comments. And then during the second part of the session, we will be discussing a case. And it's going to be Dr. Ralph Leugner. Welcome, Dr. Leugner. Thank you for being here. He will be describing a case related to medications for substance use disorders, of course. And this is the part of the session where we invite all of you to express your ideas, your perspectives. Please just make sure that you just raise your hands and wait until we call your name before muting your microphones. And this is to ensure that all of you have the same opportunity to participate in this conversation. And with that, we're going to start with some introductions from the experts, the TxRx Hub experts. Crystal Walker, nice to see you.
It's so good to see you, Andrea. So Crystal Walker, doctorally trained PA, and I am the Director of Medical and Clinical Services for MHMR of Tarrant County, which is in Fort Worth, Texas. Welcome, everybody.
Thank you. Dr. Kowalczyk.
Hi, Alicia. Dr. Kowalczyk. I'm with Baylor College of Medicine's Department of Family and Community Medicine. I'm an associate professor, boarded in family and addiction medicine, and I'm also medical director for Santa Maria Hospital.
Thank you, Dr. Kowalczyk. Dr. Waklu, welcome to the session.
Thank you, Andrea. Long time no see. Siddharth Waklu. I'm a professor of psychiatry at UT Southwestern. I'm the chief of the addiction division and the director of the addiction psychiatry fellowship here.
Thank you,
Welcome,
Dr.
everyone.
Waklu. Thank you. Is Dr. Chaudhary with us? Dr. Chaudhary, would you introduce yourself, please? Right, so I think that we can now introduce our case presenter. Dr. Leugner, would you like to briefly introduce yourself to the group, please?
Certainly. My name is Ralph Luckner. I'm a internist in Pampa, Texas. If you've watched the series Yellowstone, you'll remember Pampa has no tourists, and there's a reason for that. It's a rural Texas panhandle town. It's a little rough around the edges, and we have a lot of interesting patients here. So I'll look forward to telling you about one of them.
Wonderful, welcome. And now I think that we're ready to start sharing our didactic presentation. And I would like to ask our speaker of the day, Jackie St. Germain. Welcome again to TxRx Echo. And if you could please briefly introduce yourself, and then after that, we can take it away with the presentation. Thank you.
Perfect. Good afternoon, everybody. I'm Jackie St Germain. I'm an LCSW MBA. I'm with UT Health Houston, Behavioral Sciences campus, and I serve in the role of overseeing all business development and the overlap with managed care. So I've done managed care for about 30 years now. So today, when I was asked, I was very honored and very excited to be here with you. So thank you.
Wonderful. So we can start sharing your PowerPoints.
Yes, ma'am. Let me see if I can get this up. I did get it up a minute ago. Okay. So can you all see this? Yes. Okay.
Yes, we can see it.
So I like to get started kind of talking a little bit about managed care contracting, and starting with kind of an understanding of who managed care is. And so I'm going to move a little bit rapidly today through this PowerPoint, and certainly look forward to any questions towards the end. But I want to make sure that everybody understands this is kind of the perception that people come to when we talk about contracting. They're like, oh, we got to do contracting now. And I want to make sure and assure you that most of the people I deal with daily, a lot of them are actually clinicians. They have a deep heart and passion for what we do, and they're very compassionate. But there's also some reasons that we have kind of changed, managed care has changed over the years, which I'm going to explain in just a minute. Um, I was asked to share this slide. I have nothing to disclose, and I'm happy to be here today. And I don't know, do y'all need to read this, or is it okay if I move forward?
It's
I don't
okay.
know.
You can continue.
Okay.
Yeah.
Everybody has different ways that they need to do that. So this is what we're going to be covering today. We're going to talk a little bit about the world of managed care. We're going to talk a little bit about some terminology, and we're going to talk about some tips and tricks that I've learned over the years with managed care negotiations. So let's talk first about what I call the pendulum effect. I want to move back to when I said that managed care people are actually really pretty terrific people. I've developed some really neat relationships. But what I've noticed over the last few years is the pendulum has swung, and I think we're kind of swinging back towards the middle. When I started in the early 90s, things were fast and loose. You know, we got our rates, we got lengths of stay, we got whatever kind of we wanted. It was great. But what happened around that same time was we saw some concerns around patient rights. We saw lengths of stay. We saw some issues with payers that happened. And the pendulum swung to the other side. Very conservative. They said, most people say they start with the answer no. You walk, call, pick them up, and they go no. That's not true. Most of those people lived during that time. And so through some of the processes that happened in that time, they had to swing the continuum to being very conservative. But with that being said, if you understand and you work carefully with managed care companies and you work with the people, get to know them, they are actually incredibly generous and kind. I've got a couple, not so much, but in general, I really enjoy my work with them. But first, we need to understand what's important to them. You have to understand what is important to a managed care company. The first, and again, it came out of that period of time, is controlling costs. We understand that healthcare costs are growing and they continue to grow faster than GDP. So they're very interested in making sure that services that are being rendered are appropriate, and that what's being rendered to patients is what needs to happen, not only happen, but happen at the level of care that it needs to happen. They do like competition. They like it a lot. Because the more providers, the better access to services, the better access to options and opportunities for their individuals to get better. They're very interested in quality. So they love quality metrics. If you're doing whatever you're doing to measure your outcomes, super important, and I'm going to get to that in a little bit. They love if you're doing pre and post, pre, mid, post. They love all of that. Their goal is also to look at ways that we can improve systemically things through population health. People kind of worry about that a little bit, and I said, well, think of it this way. They may be doing some studies on gender. How can we help in certain areas, women versus men? Is it applicable cross sector? What are we doing there? How does that look? And this is a great point to talk about what I call pickups. So I always ask when I'm on the phone, do y'all have any pickups? Now, some of this, by the way, y'all, is my terminology. So I will stop, and try and backtrack if, folks need me to. But pickups are when they're really interested in something and they say, I'll give you an extra amount per day if you will monitor this for us. And actually, some of the monitoring has been very next to nothing. I mean, so they just want to know some outcomes and they'll give you an additional $50, $75 a day. We also had what we called, bridge appointments. Are you getting those patients to their next level of care appointments set within 7 days? And they would additionally tag on an extra $100, for inpatient care, a little bit less for the lower levels, but nonetheless, it was a considerable amount of money for what you're doing already. You should be doing that, providing that next level of care. And they're just asking that you provide that documentation. So they do love preventative services. They like to know what are you doing to try and help individuals because their goal is to not have them at the highest level of care. What are you doing to try and help? Again, sometimes there's some pickups there. When they say we're really interested in something, ask if, is there anything that can help us from a cost-wise standpoint, monitor that for you? And, they say yes. Actually, Jackie, we're offering a little bit, I can send you all those templates and forms. We're open to how you're monitoring it. And then we make a decision from, internally operations. Is that something we want to monitor? And is it worth the money that we're going to be paid for it? So I always, and I have a much lengthier sheet of terminology. When I learned managed care, I learned under a wonderful woman who would not let me even touch a contract until I could literally pass a quiz and literally explain every single term. She said, you are not getting on the phone with a managed care company unless you actually talk their lingo. It doesn't make sense and you will not do well at that. So I just kind of put a few of what I consider some of the basics on here. Contractual year is really important. So it is a contractual year for a managed care company is a rolling year. And it may not be on a calendar year. It's on when the effective date of your contract goes into place. But you don't start negotiations on the contractual year. I started the quarter before. So let's just say your contract year starts in January, just happens to be January. I'm starting those discussions back in the fall. And they know I can't negotiate it yet, that I'm starting that negotiation process. What will you give me? What will you not? Can we talk a little bit through this? Because otherwise, what happens is that one of the next terms, it's the effective date. So if I start on January 1, I'm not going to be out of legal. I'm not going to be out of their legal, my legal. They agree, I agree, peace. And they're going to also tag on the load time. So I need to start in the fall if that's the case. So we start talking. They said, Jackie, we're not going to do anything until January. I go, I know, but can we kind of settle on an idea of around where, we could be? The average managed care rate increase is usually around 1 to 3. And most people settle in there. I'm usually around 7 to 8% of charges because I just feel like there's ways to get those additional per diems and those additional raises, which I'll talk about. So the load time is the time that it takes them to get that into their system. So let's say you've negotiated the rate effective date January 1. They're going to come back and say, well, I got my load time, for me to get it into the system, that's going to be 60 days. That's fine. And I don't usually ask the question. I say, that's fine. We're going to go effective and retro back to the date. So when you submit those charges, you're going to bill me back. You're going to pay me at the rate. That when is the effective date? I know it's not going to be in your system, et cetera, but let's make it effective. They can also negotiate with you around the load time. So they typically out of the gate are going to tell you 60 days, and I usually get it down to about 30. So they're going to ask about who are your practitioners. Do you have mid-levels? Do you have physicians? You should have a list of all of your professionals. Are you using LCSWs? Are you using LMSWs, LPCs? Who is it that you're using? That's really important. And please don't go to a negotiation and not know the difference between Medicare and Medicaid. I can't tell you how many people get on the call with them and they get them mixed up. Well, they're going to know right away you don't know what you're talking about. And understand that every plan, let's just talk a couple of the big plans like Blue Cross, Aetna, Cigna. They all have PPOs, POSs, HMO plans. So you should negotiate them all at the same time. You get what I call one bite at the apple every year. You cannot go back and say, hey, we're adding in this new program. Could you slide me in a rate on that? They're going to say no. You do that one time a year. Your effective date rolls around in January again. So that means you need to know exactly what your intents are to do in the next year. And they assume that because they're not going to spend the time. They've had a lot of layoffs, reductions in forces, and so they may have one person covering a very large area, and they're just not going to come back to that table again. And that's also the reason I start the quarter before the effective date. So pre-auth, pre-cert, verification of benefits, concurrent reviews. Sometimes I get on the phone and people get those all jumbled up. They are very different terms. Make sure whoever is talking about that understands and is able to clearly state one. If they say we are having issues with your pre-certification process, know that they're not talking about the pre-auth, and they're not talking about concurrent reviews. So knowing your terminology is extremely important. And sometimes they have waiting periods. Sometimes they're going to come back and say, due to whatever's going on, your world, our world, the big world, we're having a waiting period. But I'm going to talk a little bit about always staying up to date and relevant with your plans and knowing what's going on. So where do we start? So I have a 3-step methodology. Notice step 3 is starting contracting. Before that are 2 very important steps. I would strongly advise somebody not to go straight to contract negotiations. You're not going to be happy with it. You're not going to come out with what you want. And they're going to be frustrated too, because they're going to have to back up and try and tell you some of these pieces that they're going to want. And they will start with the answer no. So how are you perceived? If you have never done a SWOT analysis, you can Google that. You can take a peek at it, look at what that means, how to do one, and what that means, your strengths, weaknesses, opportunities, and threats. So do that both internally every year on yourself, and have outsiders do it. Because we all have our perception of how we're doing, but how do other people perceive us? Because they know that. And what quality metrics do you have to prove that you think that's your strength, but the metrics don't agree? One thing managed care is extremely good about is keeping metrics, certain metrics, and they love it when you come with patient experience metrics. How are you measuring that, etc. So what is your service line strengths? So sometimes I'm negotiating, I call it sacrificing a service line. So it sounds terrible, I guess, but it's really not. In other words, we may want one of my service lines. If I have like 6 different programs, one of my programs is the program we really feel like we would like to go after a rate on. I may say, okay, I won't take as much money on this one on a rate increase this year if you'll give me this one, because this is the one I want and this is the one I need. And here's why. So you should have a very clear, like 2-page document, very curated, very well written, very beautiful, glossy about what you do well and how you know that. Are there any things have you gotten any accolades? Are you Joint Commission accredited? Have you gotten anything different? Put all of that on that one page because those are your talking to points with the insurance company. And you definitely need to understand your competition. Now, this is an important point here. An insurance company, since thankfully, thank you, Jasmine, for telling me it's mainly Texas people, a lot of times they're going to try and compare you across the state. You don't want that. And you can ask them, say, when they come back and they say, well, we have too many providers. Okay, what area are you looking at? And they go, well, the state of Texas. Well, that's a pretty big area. So they're automatically going to start with that. Can you narrow it down? And then they say, well, okay, we'll narrow it down to, and I'm in Houston, so we'll do it all of Houston in the CMSA, so the Consolidated Metropolitan Service Area. And I said, well, that's a big part area too. In the area I'm talking about, we don't. So can you please narrow it down to these zip codes? Compare me against my competitors here in my area. So you can request that, and they will do it, but you have to know to ask for it. So still under assessment. So performance. How are you financially performing by each plan? You may not want to go into every network. This is a lot of work. So if, the reason you negotiate for contracts is because you want blocks of business, right? You want a whole lot of lives coming through. If there are not a lot of lives in a plan, I would stay out of network. I've told many people when I did a lot of consulting, I said, why would you go into that? They don't have that many lives. It's going to take a lot of time and you're going to have to negotiate off of charges. So instead, just bill charges and stay out of network. But go in and really focus on the big plans. Now, when you negotiate and contract, you can ask them, it's called lives in my marketplace. How many lives are in this marketplace? And I mean, not all of Houston CMSA. I'd really like you to narrow it down. They absolutely have that data. Now they'll run a report. It'll take them a couple of weeks to get back to you, but they'll say, Jackie, in your service area, I've got 1 million, 2 million lives. And now we're talking. Okay, I definitely will, want to get into that plan. And I set that parameter over how much, do I want to be in that plan? Are they paying us well? So if you're negotiated, say at a rate, let's just say, toss out a number, make it easy, $1,000 per day. Then are they denying us a bunch of money? So that takes off what I get. But before you ever talk denials on a managed care company, make sure it's not your fault. Because I promise you, they'll go, well, yeah, but you aren't documenting or you aren't using the portal. So make sure that you're really understanding that. And also be able to talk about any significant changes in services. So every year, I'm constantly coming back and quarterly updating them on, hey, did you know about our new providers? Did you know about this? Did you know about that? Those are really important to do about quarterly with them, and I'll talk about quarterly report cards in a minute. And also objective measures on quality of care are real important. So when was the last date of rate changes? That's really important. I went into one facility in Colorado. Literally, they were dusting off their binders that had managed care. That worried me. And they had not renegotiated those rates for almost 15 years. So what was relevant 15 years ago was not relevant today. And so now the managed care company was thrilled. They didn't have to pay any more. They were paying way below market. And the CEO said to me, yeah, but we get a ton of business. I said, yeah, and you're below your cost structure. So you're not getting paid fairly. And so when I started talking to those companies, those plans in Colorado, they were like, Jackie, we don't have built in to get you up to that number. So that's where I talk about an escalator. Okay, that's fine. I get it. It's not in your plan to do that, but you've gotten a nice pass for a long time. Instead, what we're going to do is we're going to go ahead and negotiate an escalator. An escalator means for the next few years, you've pre-agreed on a certain percentage rate. So the first year in that particular place, I asked for a 12% rate increase. Next year, they agreed to an 8%, and the following year was 8%, which got them up to market value. Does that make sense? So that's an escalator. But with an escalator, and I like escalators, but you better be sure that you can add in services, but you can't go back and change it. Contractually, you're bound to do the escalator for those three, you can do 2-year escalators, you can do 3-year, you can do as many years as you want. And by the way, if you have any of your contracts on auto renewal, take them off. So what that means is if you miss the deadline annually, you're done. You've agreed contractually to auto renew and to re-up at the rate you're in. So I take everything off auto renewals almost immediately. And most people check that box because they don't know. And they also don't look at the inclusives, the exclusives in the contracts. So all of this is done before you ever start contracting. It's laying the groundwork for that. You should trend your charge masters. You should look at any contract languages, that's inclusives and exclusives. So some people negotiate inclusive of the physician, and that's fine. I don't particularly like doing that, but if they say we want to include the physician in your rate, I can do that, but that means we're going to have to raise our rate to cover that because it's kind of a easy way to get a little bit extra in there and not have to pay for it, if that makes sense. So carefully look at your inclusives and exclusives. Usually it's physicians and psychology or psych testing that they kind of add in there. So strategy, we've moved to strategy. So assess, and by the way, Andrea, if you'll just give me like a 5-minute when I'm almost there, I will make sure that I'm mindful of y'all's time.
Sure, thank you. You have 3 or 4 minutes more.
Okay, so we're going to have to move rapidly through these last slides.
Thank
So
you.
we're into strategy. So assess their payment plans, negotiate the lowest of the highest, and you establish a minimum target over the 2 to 3 year period. That's the escalator. You prioritize the contracts you want to go on, and I'm usually prioritizing based upon the lives in my marketplace, along with who's high and low on payment and how much business are we getting. And then again, this is kind of a refresher of the last two before we move to negotiations. So in negotiating, so who's on the team? Who's on team negotiations? Who you pick is equally as important as who's on the team. So the person that negotiates has to be someone who is pretty assertive, tenacious, but is a great mediator, and people like them, and they're a people kind of person, but they really know business. That's a really important role. And there's lots of tricks and strategies around negotiations that won't have the time to go into today. But there's a lot of things with that. I typically partner with a business office person. They do the credentialing because that's all the filing of the applications in the annual, and I manage the actual negotiations. She's the business office person, is not good at that piece, and I don't want to do the other piece because it's a lot of, labor in terms of online and form completions. What is your process to escalate? So if they say we're not doing it, how are you going to do that? And who's the final decision maker? So I'm very clear that, look, I'll take this back for you. I don't think this is going to fly. But this is what we want. And it never stops. So if you go to the contracts once a year, you're not going to win. You need to I love report cards. I ask for report cards. That's a quarterly meeting. I call it report cards. They know what I'm talking about. But it's their metrics of how you're doing. Go to those calls very carefully. Make sure the people on it are not going to get defensive when they say your length of stay is too long, this or this and this. Make sure who's on the call is equally important. And listen, because that's how they are perceiving you. That is their metrics. Now, you can pull things out. Like they say, your length of stay is too long. I go, well, wait. can we take a back up with me here? Can you send me the names? Because I know we had some readmissions that had extremely long lengths of stay, and I'd like to pull out the outliers. And when we pulled out the outliers, it was fine. We were actually in good spot. So you can do that. I do it. It gives me a reason to talk to them. And I also stay on top of in those calls. I go, hey, can I call you later? I'd like to see, I think you guys have some new stuff coming out, and they may not, but they always tell me about something. If they have a portal, they usually like you to use it. That's the method to submit your claims and your concurrent reviews. And I highly encourage you to develop a relationship. These people are actually, in general, pretty nice and reasonable. A lot of them are back from that period of time where there were a lot of concerns. Once they know that you're fair, reasonable, and honorable, they're usually pretty easy to work with. These are some references, and I will open it up now for any questions. I know I'm very close. I'm sorry I had to rush through those last slides. My apologies. But did you want me to take a few questions, Andrea, or are we completely at time?
Yes, thank you. Thank you. This was very useful, valuable information. So I think we're going to open the floor briefly to any questions or comments from participants or the hub.
Yes, Dr. Lickner?
Yes, thank you for that presentation. It's certainly something that we have to deal with in the real world, unfortunately. Now, I'm a very small clinic. It's just me, really. And I see a lot of patients, and we do a lot of great work. But I find that as a small clinic, I'm not really in a position to negotiate with companies. Do you have any suggestions in that regard? And then also more to the point, and this will get more into my case, is that um, we almost find that if we put in something like substance abuse treatment, that they deny our complete claims. So we actually don't no bill substance abuse treatment. We just bill our medical to avoid problems with the claims. Do you have any suggestions for us?
I do. I've actually, and Dr. Lignar, I'm also happy to talk to you offline a little bit about that because I think the claim piece is something I've got some tips and tricks on that too, if you would like.
Yeah,
Sometimes people do focus on the psych piece. It can be a little bit easier. It shouldn't be, but it does. I've also would suggest, since you're a physician, that most of the major companies have peer physicians, and a lot of times just make sure you're talking to somebody who's in the same field. Sometimes
right.
when you guys get on peer review, it may not be somebody who's knowledgeable in psychiatry. And so we request that in terms of time frames, and I certainly feel your pain around that. I would definitely look at what are the big players in your area and
Mhm.
then probably just look at one or two. And I think then that kind of helps focus you. And also, are there some that are really, really lagging behind in terms of rates? And they're even below the state rate. I came into a facility and they were paying us below what the state rate was. They were thrilled. Not so much me. So, some things are harder to negotiate. So the managed Medicaids fall in at exactly the rate that is set by the state, your Medicaid rate. There is CHIRP funds that you can look for if you're not familiar with those. CHIRP does have some funding streams. You just have to fill out, they've closed that time. It's a very quick portal. You can Google it and access it. But I'd be happy to talk with you a little bit more offline.
Thank you.
Mhm.
Thank you, Jacqueline. And I think we have time for one more question before we move on to the case part of the session. Questions from the group? And I just want to remind you that this great material is going to be shared with you all after the session. And if not, that's fine. We can move to the case part of the session after the announcements, and we may revisit this part and come back to the didactics as we study the case. So let's go and do some quick announcements. Karen, please.
Thank you.
If you need CMEs for today's session, all you have to do is text the code attend 100 986 80 to the number that you see on the screen. It's a very easy process, but if you have questions, you may also send us an email here at cstat@utesca.edu. Next. We're always looking for case presenters, so if any of you here in the session is interested, you or your organization, to discuss a case with us, it's fairly easy. We will provide you with a short, easy to fill form. Just send us an email and we'll be happy to give you some guidance and ideas through the group. Next. And our series Maternal Health Echo it happens on the first Tuesday of the month. We are sharing with you the registration link. Great series. It's beautiful collaboration between BeWell Texas and Perry Pan. So again, it's the first Tuesday of the month at 12, and please register. You're going to like it. Next. And we are excited to present our Texas session. We have Dr. Ramesh, Dr. Escamilla, Dr. Freeland, and Alana Bolton. That is Friday, May 9th. That's tomorrow, so you're still on time to register for the Texas session. Again, we are sharing with you the link tomorrow, May 9th at 12. Next. And we're still looking for candidates for the Mood Mentoring Program. Please contact us if you're interested in being part of this program. Sign up for free for mentorship by leading experts on delivering medication for opioid use disorder. It's a one-on-one guidance at your own pace, at your own schedule, case consultations, and implementation support. So just contact us, and here's the link, redcap.link/mood mentoring registration. Please contact us and we'll be happy to help with that. Next. And of course, Thursday, May 22nd, the second session of the month. Please don't miss it. And I think we can share the case presentation right now. And Dr. Lubner, if you could please briefly walk us through the case. Thank you.
All right. So I'm happy to present a case. I usually have pretty complex patients when substance use disorder is involved, and this is no exception. So I have a 51-year-old male, Caucasian, and the questions that I'm just kind of prompting you with as I go through this are, number one, what strategies might help overcome financial barriers to consistent counseling this particular patient. Also, you'll see that this patient's on a number of medicines, and not all the medicines are even shown. So what is the buprenorphine dosing strategy for a patient who reports inadequate pain relief at 24 milligrams of buprenorphine and 32 milligrams even. So, and then finally, best approaches for managing chronic pain and opioid use disorder with neurological deficits and mobility issues. So this is a patient. He's a former smoker. He quit in 2020. He had a 25-pack year history, and he had heavy opioid use in the past until 2023 when he came to us, and then 25 years of abuse with pills and IV. And his wife also had substance use disorder. He suffered a massive stroke, and that significantly affected his health and brought about a lot of changes. So the primary substance use disorder diagnosis is opioid use disorder. It was quite severe. It is controlled now with buprenorphine, but he's requiring a very high dose beyond sort of the saturation dose, if you will, of 24. He's up at 32, and he's even paying for that himself for the extra pills. I'm sorry, extra films. So moderate buprenorphine withdrawal. He couldn't go down to 24 because his pain wasn't controlled and he was having withdrawal symptoms. He also has a number of co-occurring mental health diagnoses: severe bipolar disorder with depression. His PHQ-9 was 14, JD7 was 4. He has insomnia with sleep apnea, and he's being treated with CPAP. I also have some PANSS scores for those of you that know about that survey. Positive 10, negative 33, Gen 48 out of 112, treated with fluoxetine, risperidone, trazodone. He was transitioned from Seroquel to risperidone because he was just sleeping all the time when I was treating his bipolar with Seroquel. As far as past medications for substance use disorder, he wasn't treated before he came to us. He actually started on the Be Well program, and then once he got insurance, he was not on a Be Well program anymore. So he's on the Suboxone 4 times a day, 32 milligrams, and pays out of pocket for the extra doses above 24 milligrams because insurance doesn't cover it. He's not had any inpatient treatment. We've given him counseling and with a licensed counselor in addition to the counseling that we provide. He's missed follow-ups due to a fee after the 3 initial sessions with the counselor. He hasn't gone to any mutual support groups. He basically strongly opposed, if we try to get him in with peer support, he says no, he doesn't want to do that. As far as harm reduction, we frequently give naloxone to our patients. He's gotten that, and also we've prescribed it to him. As far as social conditions and the psychiatric history, support system is his wife. She's also in treatment. And they have school-age children. The wife works, and he stays home and watches the kids. He's significantly disabled. He has we'll go see later. He's got hemiplegia and mobility issues, fatigue, heart problems. So they only have one car, so a lot of times he can't make it in, and we can do televisits with him, but he likes to come in when he can. His wife has to bring him, or at least the wife's car has to be there. Single family home, rural small Texas town in Pampa here. He's not employed, he's on disability. And then we've already talked about his mental health comorbidities. I've checked I always check the PDMP for every controlled substance prescription. He's 100% compliant. He's only had controlled substance prescriptions from me. And he's had some small gaps where he didn't follow up in time, and he needed to get in for his follow-up appointment. These are just 4 of the medications. He has several others, but he has a Suboxone 4 times a day for opioid use disorder and also pain management. He has some pretty significant neuropathy. Rivaroxaban, 20 milligrams daily. That's for, he had the massive stroke, and then he also had a giant clot in his heart. And then secondary CVA prevention is critical. Fluoxetine, we have 20 milligrams nightly, and also risperidone. We were on Seroquel, and he wasn't tolerating it well due to fatigue. I switched to a lower dose of risperidone. I'm thinking about going up to 0.5 nightly for that. As far as his medical comorbidities, I've already told you how he's had multiple venous type thrombi in the brain. So basically, very significant hemiplegia, and his strokes have been a big motivating factor for him to get his opioid use disorder treated. He also has, from his smoking, he has COPD, and he saturates to 90% with minimal exertion. That's also partly due to his heart failure. He also has hypertension, and as far as chronic pain goes, he has sciatica, shoulder pain, knee instability, and he also has the specifics on his heart failure, diastolic heart failure is chronic, and then he previously had a low ejection fraction, but it recovered. As far as the current treatment plan, we have Suboxone, as I mentioned before, QID, 8 milligrams each, so that's 32 daily. Rivaroxaban, 20 milligrams with hematology follow-up. He's had some anemia, so we wanted to see, is he bleeding from somewhere or what's the problem? I'm looking to increase the risperidone to 0.5 at bedtime and while tapering the trazodone to better manage his bipolar symptoms with less sedation. He's been on CPAP therapy. Gabapentin is also in the mix. So you have a lot of medication interactions here. Continuing also with the blood pressure medicine, lisinopril, metoprolol, hydrochlorothiazide. Those medications are controlling his blood pressure very well. He's pending pulmonology evaluation. We've done some CT angiograms periodically to check for any thrombi. Physical therapy has been helping quite a bit, but he's limited in how much he can participate, and also his motivation is somewhat low in that regard. Monthly follow-ups to monitor medication efficacy, side effects, and coordination between specialists. And then counseling, it's not just a problem with his case. I mean, just getting people into counseling and being able to afford that. A lot of times their insurance only covers a particular counselor who's not very good. So here we are. So that's my case, and I'm really happy to take any questions.
Thank you, Dr. Lugner.
Excellent case. When did he have his stroke? How long ago was it?
So he's had several strokes. He started having strokes in 21, and he's just had repeated strokes. He had another stroke in 23. I think he's got coagulopathy some kind. And then with his heart failure, that, is kind of a setup. So that's what's going on there. He walks with a cane, and he can walk maybe 20 yards, and he's just beat. And that's also a source of great depression for him.
Hi, this is Alicia, Dr. Kowalczyk. Thank you, Dr. Lechner, for presenting this really complex case. Speaking to your question, kind of number two, and what to do about the bupe dosing strategy, at 32 milligrams, we're pretty assured that over 99% of his opiate receptors are saturated with bupe. So I don't think that going up on that is going to give much additional relief, right? And we also know that opioid receptor activation isn't that effective for chronic pain syndromes. So I think you're probably maxed out there, and it is good that he's doing the 4 times a day dosing if he's able to manage that, because it does spread out that the pain control from bupe is not as long as the control of the opioid cravings, for example. So I think you're doing a good, as much as you can do for him there. Yeah. And so, I think any apps or anything that might be available to him, and I think this came up in an earlier discussion of your case we had with our faculty team right before, some apps that might be available for kind of the counseling, mindfulness, some of the evidence-based strategies that help folks with chronic pain, not just his SUDS, which sounds like the opioid use disorder is well managed now. It's more the other things around his disability.
Yes. In terms of the apps, he's not in Be Well, so he can't. And he also used that app I don't know if he used, actually, I don't think he ever used the app. He's not an app kind of guy, you know.
Okay.
I put some of it in the chat for you, Dr.
Okay.
Luckner,
Oh,
but
yeah. Okay.
the VA actually has a pain coach app that is
Okay.
specifically surrounding pain and pain management. And I also put a link to the American Academy of Family Physicians
Mhm.
because sometimes when you just focus on pain, right? Like what's your pain scale of 1 to 10? Um, Patients can lose sight of some of those things where it sounds like he's already getting into some maladaptive
Mhm.
issues where he's withdrawing, he's not being social, he's not interacting, he's not engaging with some things, right? Like
Mhm.
he doesn't want to peer, he doesn't want to use the app, he can't get out of the house because he doesn't have a car. So the American Academy of Family Physicians has some great tools to be like, okay, like we're not going to make your pain 100% go away, but what are some goals? Do you have some relationship goals, some, functionality goals? And could that goal just be participating in physical therapy? And let's look at that aspect of controlling your pain instead of making you pain free. Because, like Dr. Kowalczyk said, 99% of his receptors are saturated. Like medication wise, you're maxed out on that butte, but looking at functionality, that might be more a different way to focus your treatment or the goals for the patient.
What do you think about the gabapentin? We tried him on pregabalin. He didn't do well with that. And I'm not a huge fan of gabapentin anyway, but for cases like his, he's not a diabetic. It's just neuropathy associated with his strokes, I guess.
I mean, if it's working for him, if he says
Mhm.
that that's helpful for him,
Mhm.
and he's not over sedated on that, I think that's okay.
Okay.
And especially if he feels, it sounds like he may be more medication focused, because he's
Yeah.
been kind of pushing back on anything that's, less than medication. Um, and so, I wouldn't die on that hill, so to speak,
Yeah.
if that's something he's finding valuable, um,
Right.
and framing it that way with him as well.
Yeah.
Those risks, but that you're appreciating that, he's saying this is helpful for him, and he's not sedated on it.
Also, another thing that I think is a factor is his wife also has substance use disorder that we're treating. Um, when I try to kind of understand the dynamic there, I don't even really know what to ask sometimes. How does that typically play a role or not play a role?
Dr. Luckner, what's her drug of choice? What's her
Well,
diagnosis?
hydrocodone and
Oh, okay.
I don't know what he used IV, but
No,
it's
no, the wives. I mean, the wives.
oh the wife. She actually she's in treatment too. She's also on Suboxone,
Oh, she, okay.
and she's on a lower dose than he is. She doesn't have these pain problems with neuropathy, and he's a he did a lot of oil rig kind of work, so he's got all kinds of chronic pain from that too.
So, Dr. Luckner, his psychiatric diagnosis, this you said bipolar disorder, is that
Mhm.
he has had previous psychiatric hospitalizations? Has anyone ever witnessed a manic episode or
Well, I mean, I think that he could definitely benefit from seeing a psychiatrist, but unfortunately, there's a lot of stigma associated with that, and so I haven't been able to convince him to see one. But as far as manic episode, yeah, he's definitely had manic episodes, but it's more depression focused right now.
so manic episodes that have been witnessed by?
Yes, yes,
Okay.
but it's more depressive lately.
Dr. Wims, would you like to unmute yourself and expand a little bit more on your comment here in the chat? Dr. Wims. Oh, he says he has bad reception. So I'm going to read, he says here, I would watch for toxicity anytime there is GDMT, titration, or acute illness, given significant renal clearance with the gabapentinoids and his risk factors for kidney disease. That was his comment on the chat.
His kidneys are good. There's no chronic kidney disease, so that's at least a positive.
There's a comment.
Sandra?
Yeah, there's a comment from Sandra.
Yeah, I was
Sandra, go
gonna
ahead
ask.
if you want to talk about that. Yeah.
Yes, Sandra.
Hi, I'm Sandra Flores. I am a counselor at Abilene Absolute Recovery Solutions. I've been working in the field of opioid treatment disorder for about 30 years. We've had some luck with some of our patients who continued to complain of withdrawals when they were at the max dose of the buprenorphine. They have added duloxetine to their regiment, and it seems that some of their pain has subsided. I see that you're giving him fluoxetine for his depression. The duloxetine helped with the pain, and it also helped greatly with the depression. When we added that to their treatment, mood improved, outcomes improved for the individual. So, have you thought about that?
I've thought about that, and I think that I was a little bit worried about the sedation aspect of that medication. He's just so fatigued, and so I don't know. That was one of the things I was worried about, but it's definitely worth a try.
Right. We haven't seen it being sedative to our patients, and they usually take it during the daytime as well. So,
Okay.
Dr.
Good.
Luca,
and it seems like it has less of a impact on their heart conditions as well, since you said he had heart
Yeah,
conditions.
he does.
Yes.
Dr. Luckner, it's an Cymbalta is an SNRI, so you're less likely because of the norepinephrine component, less likely to have sedation. I mean,
Okay.
SNRIs are more likely to cause. So you're if you're worried about sedation, I wouldn't worry about SNRIs and sedation.
Okay,
They're
good.
more activating than SRIs. Yeah.
Excellent.
I just had one additional comment, and I know access to care is an issue just based on his rurality, but they do have virtual palliative care programs, and he's really, with all his comorbid conditions, his heart, his mobility, his breathing, he might benefit if he were receptive um, to a palliative
Specific
care
ones?
assessment as well.
Do you have some specific ones that you're thinking
Um,
of?
I can send you some links. I mean, I'm just Googling here as
Okay.
we're speaking, some palliative care that list as virtual in Texas. I don't know, Vitas list as virtual in Texas. I can send you links afterwards.
All right. Thank you.
Hello, this is Tessie Cadabel, I'm a nurse practitioner. I have a suggestion. Usually, these people with the substance use or any chronic illness, their uric acid tend to be high, which causes a lot of inflammation. And in my practice, I know I am a favor of treating, identifying the chronic inflammation and checking the uric acid and treating them. And I'm finding a lot of, improvement with the neuropathic pain and, other pain with the lowering uric acid level.
Okay. Yeah, I've checked his uric acid. It's actually okay. So he does have inflammation, but it's more just from the arthritis.
Yeah. Usually what happens with the uric acid is, are the blood level maybe within normal, because high uric acid, once it go above the normal level, it precipitate and go into a needle-like crystals, and that can cause inflammation and blood clots in the circulatory system. So before even it goes high, it is removed from the circulatory system and deposited in the different organs. So that's what, and that what I do, I just try, just see it and try it. And if it getting better, better. If not, just stop it.
Right, right.
Thank you. And in the interest of time, I'm going to ask Dr. Kowalczyk if you could give us like a little summary of the case and some of the recommendations discussed today.
Yeah, so the case is of a 51-year-old male who lives in rural Texas, that's on max dose of buprenorphine 4 times a day for both his opiate use disorder, which is well controlled, and chronic pain, which is not, with significant comorbidities, including psychiatric comorbidities and medical comorbidities, including multiple strokes, impairing function, cardiac and pulmonary comorbidities. And so trying to work with the patient around online resources he may be willing to engage, such as various apps that can offer therapy and strategies for managing chronic pain beyond medication, which is really pretty well managed for him in terms of medication wise, looking into possibly palliative care input, given his multiple medical comorbidities that are impacting his pain and function as well. And then, supporting the patient, staying connected with the care that he is getting, because he has gotten into recovery through that care, and an ongoing relationship with your practice, Dr. Lechner.
Thank you. Also, duloxetine. I think there was another.
Oh, yes, duloxetine.
Yeah.
Thank you for that, Ms. Bedon. Sorry.
All right.
I want to
Thank you
thank
so
all
much.
of you, and very especially I want to thank our speaker, Jacqueline St Germain, our case presenter, Dr. Lugner, and to all of you for a great session. Please don't forget to answer your post-session survey, especially if you're interested in your CMEs. And I will see you in 2 weeks, actually. Thank you to all.